Thought I would really quickly talk about the eye muscles just in case there's any confusion, and I know it can be pretty confusing. So I first wanted to just note that the superior oblique and the inferior oblique are working sort of to intort and extort the eye, so it sort of moves it sideways. So basically, if I were to let's say move my head to the left, so I like side bend my neck to the left, the entire world doesn't move everywhere. I still know what's up and what's down just because my eye orientation changed. So that's what these obliques are doing, and that's why it seems kind of weird. So looking at this is our anatomical action of the eye, and then here's our clinical test. So the clinical test and the anatomical action are different. The first thing that's important to know is what cranial nerves these muscles do. So we've got our SO4, LR6, all the rest three. And the way I remember these two apart is SO4, it's like back to organic chemistry again. So I can see that's that was a structure where SO6 is not. So anyways, that's how I keep them apart. But SO4, LR6, all the rest three. So basically, lateral rectus is 6. Superior oblique is cranial nerve 4. Everything else is cranial nerve 3, so oculomotor. Anatomical actions. So if this is medially, so this is my nose. To pull my eye in, I've got my medial rectus. To pull it in and up is superior rectus. To pull it in and down is inferior rectus. And then to pull it out or laterally is lateral rectus. If I want to go out and up, it's inferior oblique. And then out and down is superior oblique. Now these seem weird, and that again was just because of how they pull the eye and how they're oriented. So our clinical test, they're kind of different. So you can remember in EPC how you did that H test. So I'm going to draw that out really quick on here. So you've got the H. And you make this H with your eyes. With your fingers, and the person follows with their eyes. And so you would think that the eye movements in the clinical test would be the same, but they're not, because the superior rectus, middle rectus, and inferior rectus, they're all helping with medial deviation of the eye, but I have to know which one's which. So this is how I do it. So let's say that I'm telling the patient to move their eye over to the side. So this way. I'm now testing all three. Everything that's, we'll put the nose right here. So I am testing that I'm testing superior rectus, middle rectus, and inferior rectus because everything is moving medially. Then let's say I want to move up. Now I'm going to isolate. So the first thing I did was move and basically take out everything that's medial. So superior rectus is out. Middle rectus is out. Inferior rectus is out. Because all of these muscles help me look medially. When I go up, there's only one muscle left that helps move my eye up, which would be inferior oblique. So let's do another one. Okay. Let's say that I want to move my eye now out. So now it's lateral. The three things that move my eye lateral would be inferior oblique, lateral rectus, and superior oblique. So now that my eye has been moved completely lateral, those three things are almost like locked out. So I can't choose them. So now if I move my eye down, the only muscle that's left that can help me move my eye down is inferior rectus. So remember, my inferior rectus depresses and adducts the eye. So the only thing that's depressing my eye is that inferior rectus. So I hope this helps, and if you get stuck or still can't figure it out, just keep going and like thinking, okay, if I move it medial or lateral, if I move it medial first and then go a different direction, then when I move it medial, all of these muscles don't work. It's a contribution of all of the muscles. So just moving it medially is going to be medial rectus. But when I move it medially and then move it in a direction, it can't be any of those anymore. Or if I move it laterally and then move a direction, it can't be anything that's moving my eye laterally. It's got to be something else. It's got to be another muscle that can do that, because I'm locking out these lateral muscles. So I'm just hoping this helps. If not, you can always draw this out on your scrap sheet of paper, like just memorize it and know what the clinical tests do. But I just thought I would try to explain this to you so that maybe that you can understand it better. The other thing to remember is that if I have a lesion to cranial nerve 3, my eye is going to be down and out. If I have a lesion to cranial nerve 6, then remember that's a lateral rectus. So my eye is going to be focused in because I can't abduct my eye anymore. So it's going to give me that medial strabismus. Superior oblique is a little more complicated for now, but basically your head would be tilted, and you would have trouble moving your eye on a clinical test, or the anatomical action, you would have a hard time depressing and abducting your eye. So in a clinical test, the person would not be able to move, would not want to go down and in nasally. Okay, hope this helps.